Your favorite.
Yeah.
Okay, I think we are live, Aarti madam. We can start.
Right. So I'm just sharing my screen. You'll have to give me permission.
1 minute, 1 minute. Yeah, given.
Right. Just give me 1 minute. Yeah, you can see my screen.
Yeah.
Super. So, very good evening to everyone, and welcome to this blast session on ultrasound assessment in recurrent pregnancy loss. Now, there are two aspects to ultrasound assessment. One is before the pregnancy happens, and the other is when the patient is pregnant, to assess if that pregnancy is healthy or no. And today we'll focus on the pre-pregnancy assessment. And take homes we want to drive through this blast session is, remember, ultrasound is your third eye. Just as a stethoscope is important for a cardiologist, that is how important an ultrasound is to a gynecologist. And it is the easiest thing to do immediately when the patient comes to you, provided your mind and eye know what to look for. It should not just be a random ultrasound, and that's what we're going to drive through this session. And third important point is invest in a good ultrasound machine. It will save you the trouble of missing a diagnosis when it is staring at you. So with this as the backdrop, Jay, now I'm going to take you through the history of this patient who came to us. And then, of course, the way we do a pelvic scan, the transabdominal scan, and then the findings of the anterior, middle, and lateral and posterior compartment. So this patient was 29-year-old and non-consanguineous, marriage, attempting pregnancy since 2 years, history of 3 pregnancy losses. Now, she gave a menstrual history of having spotting for 2-3 days, dark colored bleeding, followed by scanty bleeding for 2 days, associated dysmenorrhea. Now, her first pregnancy, she got pregnant in 1 year 3 times, and her first pregnancy was an anembryonic pregnancy at 6 weeks, and then it was terminated medically. And then 6 months later, she got pregnant spontaneously once again. Again, at 7 weeks, there was no fetal heart, and then she underwent a medical termination. And her third pregnancy again was a spontaneous pregnancy, but this time it was a biochemical pregnancy. The beta HCG was around 200. In just a matter of 2 days, she started bleeding. She came to us, and then the cavity was empty and the beta HCG was around 5. So that was a spontaneous bleeding she had. And now she's been attempting pregnancy since 1 year, but she's not conceiving at all. So this is the history this patient has, Jay, and these are the ultrasound findings. The anterior compartment, we did ultrasound of the kidney. Both the kidneys were normally placed. Now, when we looked at her bladder wall was absolutely normal. We could see ureteric jets. We even traced the ureter, and we could see the ureteric peristalsis. Then coming to the middle compartment and the lateral compartment, you can see here, this scan was done on day 10 of her cycle. The 2D, 3D of the uterus was normal. Now, if I'm going back on this video, you can see this is a triple line and 7 mm thick endometrium. Okay, it's stopped over here. I'll just have to go back. Yeah. Then the right ovary, you can see here, had around 3 follicles. The volume was around 4 ml. There was very clear-cut periovarian fluid with periovarian adhesions. And the left ovary, again, the follicle count was around 3. The volume was around 2.5 ml. Again, periovarian fluid with this typical flapping sail sign of periovarian adhesions. So this is what we saw in the middle and lateral compartment. Posterior compartment, there was no evidence of any bowel adhesions. And now coming to your part over here, over to you, Jay. Before we go into a systematic way of doing ultrasound of the pelvis, over to you. What is your diagnosis here?
Just one question, ma'am. Have we done a 3D ultrasound as well on her?
Yes, I did not share the pictures, but the 3D ultrasound was absolutely normal, the uterus.
Okay, so I think, before I come to the diagnosis, one of the most important things which people should understand is that in today's time, sorry, doing a 3D ultrasound is one of the most important things which you need to do for any pelvic ultrasound. Forget recurrent pregnancy loss. For any pelvic ultrasound, a 3D ultrasound through the sagittal section, taking a cut section through the endometrium, or focusing onto the anterior, for focusing onto the top of the endometrium, is something which is extremely important. Okay, documentation as well as diagnosis. So just keep that in mind. That's the first thing. Now, the second thing, you asked about these peri-ovarian adhesion bands. So one of the commonest things to have a peri-ovarian adhesion band is obviously PID. Okay, and it is very, very, very commonly seen uh, as far as acute as well as chronic PID is concerned. But obviously in India, we are more worried about it being chronic PID. And this chronic PID with this type of fluid collection, okay, is usually a typical of, those chlamydia gonorrhea type infections. Okay, not very typical of tuberculosis, but very typical of chlamydia gonorrhea type infections. And that is something which we have to keep in mind, because that is a very, very, very important cause of having missed abortions in India. Okay, this is something like when we talk of endometritis, this endometritis is something which is very, very commonly seen in our country. And when you have these peri-ovarian adhesions, okay, it is something which may also cause blocked fallopian tubes, may cause mid-tubal blocks, fimbrial blocks. When you go inside and just release 3, 4 of these bands, these are going to be flimsy bands. Suddenly the tube will become normal, and you will be surprised that what just happened types. But this is something which we must keep in mind as far as this history is concerned of this patient. See, she is given history of a biochemical loss of pregnancy, and biochemical loss of pregnancy means you have to keep in mind something as far as the endometrium is concerned. So it could be endometritis, failed implantation. This is all this when I'm talking of a euploid embryo. So considering all these things, I believe, okay, that it is going to be a euploid embryo which has got failed to implant, and then that's why it has been a biochemical pregnancy. The other thing which I think is very, very important, madam, what you mentioned, anterior compartment, posterior compartment, middle lateral compartment. I think, okay, forget all this clinical examination and all these things in today's age and time. What is important for people to understand, okay, for doing a particular method of doing an ultrasound. See, the ultrasound actually starts from the perineum, even if you are looking at recurrent pregnancy loss. See, the vaginal causes, okay, they do not exist for having recurrent pregnancy loss. There is no such vaginal cause for a recurrent pregnancy loss, okay. But you must start from the perineum, okay. Partial septums in the vagina, transverse septums, vaginal aberrations, vaginal polyps, endometriosis, all these things, they actually start from the perineum. So if I just draw something for you, okay, I
You want me
actually,
to stop share?
yeah, 1 minute. You can stop share. 1 minute. I have just started share of my
Okay, I'm just
screen.
stopping. Yeah.
Yeah, just see if you can see my screen.
Yes. Yes.
You can see my screen, right?
Yep.
Okay. See, this is important. I'll just draw something which is a beautiful thing which I have taught a lot of these students who have trained under me for an ultrasound. Okay. So this is your vagina. Okay. This is the cervix and the uterus. Okay. That's the bladder in the front. Something like this. This is the rectum behind. Okay. And this is your anal opening, vaginal opening, urethra. And here is where you have the perineal body. Okay. So when you do an ultrasound, when your transducer is kept here, okay, here, this is your transducer. So what is important for you to understand is you start from this angle. You start from the perineum. Okay. Once you go from the perineum, we have a typical method of first the perineum, then goes to the bladder. Okay, so onto the bladder, it's a simple rule. Bladder pathologies don't really cause any type of recurrent pregnancy loss, but it is absolutely important for you to assess the presence of bilateral kidneys, because it is unilateral kidneys which is typically associated with Mullerian anomalies. Just keep that in mind. Majority of the people forget to do a renal scan, and as Dr. Aarti showed in her first slide itself, bilateral kidneys have to be present. Presence or absence of a ureteric jet, which you nicely has been shown and which is beautifully seen on a Doppler, okay, is something which is important, especially in endometriosis. But again, endometriosis is more so a cause of having recurrent pregnancy losses, especially when it is associated with Mullerian anomalies. Okay, don't just think of endometriosis as endometriosis, because Mullerian anomalies is a big cause of having recurrent pregnancy loss, and so many of the Mullerian anomalies have associated endometriosis. Okay, remember, whenever there is endometriosis, that means there is an obstructive pathology. Okay, just remember this line. So whenever you have an obstructive pathology, usually it will be associated with non-functional tubes. Okay, and usually it will be associated with a septum somewhere. Okay, now this septum is usually, any septum which is causing an obstruction has to be a transverse septum. So it can be a mid-vaginal, right from vaginal atresia, I mean atresia of the lower vagina, mid-vaginal atresia, upper two-third atresia, transverse septum, thick transverse septum, ovira syndrome which has a hemi-vagina, Robert uterus which has a partial septum which is extending in the uterine cavity. All these things, unicornuate uterus or bicornuate uterus with a rudimentary horn, all these things, because they are obstructive pathologies, all these things will be associated with endometriosis. And as a result of all this, ruling out endometriosis is really, really important, because it is your early clue as far as ultrasound is concerned. Okay, so after you finish assessment of the anterior compartment, then we go to the fundus. Okay, then we go to the anterior fundus, then we go to the fundus, then we go to the posterior fundus. Okay, with assessment of all these three things, obviously something important will strike you, and that is adenomyosis and fibroids. Okay, remember these two guys, especially submucous fibroids, indenting the endometrium or touching the endometrium and distorting the cavity. So any one of these which are causing distortion of cavity, okay, are a direct indication for surgical correction, because distortion of cavity is directly related with recurrent pregnancy losses. Okay, so just keep that in mind. And very, very important is, when you study the adenomyosis, don't study adenomyosis alone. Go and study the endometrial myometrial junction. Okay, an incorrect endometrial myometrial junction again is a very big cause of causing recurrent pregnancy losses. Okay, obviously when you take a 3D swipe, you will understand the presence or absence of a septum, and you will understand all these other things which are causing recurrent pregnancy losses. But this is something which is very, very important. Then you come down to the cervix. Onto the cervix, it is important that you understand that when you are at the level of the cervix, okay, there is no such great pathology apart from a cervical septum, but cervical septum is not related to a recurrent pregnancy loss. It is something which you just need to keep in mind. Okay, obviously one thing which is very intriguing about the cervix and which people often miss out is, they often like to look at these reports, bicollis, unicollis, okay, all these things. It is good to look, but the best way to examine these things, the cervix is not, if there is a double cervix, both will not be present in the same line. One cervix will be here, other cervix will be somewhere behind. Okay, so the best way to examine is to either do a per vaginal examination. I don't think that is very good. So we actually look at an examination only on vaginoscopy. Okay, I'll cover this vaginoscopy beautifully in one of the master classes, because vaginoscopy, in my opinion, is a gold standard for Mullerian anomalies which cause RPL. Okay, you will pick it up and you will treat it beautifully. Okay, once you finish the evaluation at this level, then you go from here, you go from the pouch of Douglas and you go into the rectum. Obviously, you are going to pick up deep endometriosis if it is present, rectal nodules if they are present, and that completes your evaluation as far as ultrasound is concerned for recurrent pregnancy loss. Okay, what is important here for people to remember in this, okay, apart from this diagram, okay, is that always follow this diagram. Do not change your head in case of any problem. Okay, this has to be a routine. Patient comes, you have to evaluate it in this manner only, even if there is no anomaly. Even if there are 50 scans consecutively without an anomaly, okay, evaluate it in this manner only. Trust me, it doesn't take more than 3 to 4 minutes. The whole thing. Okay, it doesn't take more than 3 to 4 minutes. If you are able to do it in 3 to 4 minutes as a routine, you would have completed a beautiful, complete evaluation of ultrasound as far as recurrent pregnancy loss is concerned. Obviously, there are certain things which you have to keep in mind many a times. I mentioned that after this, you go to the fundus. Please remember, on 3D, you get this beautiful contour of the fundus. That is a great differentiator between a bicornuate uterus or a large septum, which your HSG will miss out on. A thick septum will appear like a bicornuate uterus. Okay. Just keep one more thing in mind, which I have taught a lot of people. I'll just share the screen again to explain this concept to you. If you learn this concept, no, you will never go wrong as far as any form of recurrent pregnancy loss is concerned. See, any form of pregnancy loss, okay, any form of recurrent pregnancy loss is going to occur when there is a myometrial compromise. Okay. Now, what do I mean by that? See, during development, the uterus forms this way. So that means the myometrium which is present here, okay, all these places is a uniform myometrium. Now, when you have a myometrium which is like this, okay, which is a uniform myometrium, which has formed developmentally. So what has happened in the developmental phase? Two Mullerian ducts, both these guys came down, they joined hands with each other here, okay, and after this, they began to canalize, okay. So now what will happen is, there are some guys who will not canalize at all. So they will form two beautiful uteruses. That's a didelphys uterus. It is a double uterus. So that means this myometrium is absolutely intact. Okay. God forgot to canalize it. Sometimes what is going to happen is that one guy reached here, it started to get adherent and never canalized. Okay. That will form all the variations of a unicornuate uterus. So you have a unicornuate uterus with rudimentary horn, which is communicating, not communicating, absent communication, all these types of things. Okay. Just remember one thing, this unicornuate uterus has some defect in the myometrium at the side of the rudimentary horn, as a result of which the unicornuate uterus has a high chance of recurrent pregnancy loss, especially in second trimesters. You will pick this up on ultrasounds. Same comes as far as bicornuate uterus is concerned. See, the problem with bicornuate uterus is again a lot of second trimester abortions. The reason being, bicornuate uterus has two horns. So the myometrium here is good, myometrium here is good, but in the center there is no myometrium. Okay, so you will have a varied presentation. Some people will become pregnant and deliver. Okay, some people will become pregnant and have second trimester abortion. Some people will become pregnant and have first trimester abortion. Okay, again the problem comes because of partial presence of a complete myometrium. Okay, so just take home this point. The minute there is something wrong with the myometrium, okay, or developmentally with the myometrium, that is when you are going to experience recurrent pregnancy loss. That is the same problem which happens in adenomyosis. Normal myometrium is here. When I try to draw an adenomyosis, there is a defect in the myometrium. And because there is a defect in the myometrium in adenomyosis, what typically happens is this myometrium becomes hyperfunctional, which causes a problem as far as the implantation is concerned. I think as we go more and more into the depth of recurrent pregnancy losses, okay, sooner or later these theories which are related to the myometrium are going to pop up, and they are going to become like established theories, because the surgical correction of myometrium solves the recurrent pregnancy loss problem for all these patients. So keep that in mind, because this is going to be based on your ultrasound, and 5 years down the line, 7 years down the line, that's going to be the future as far as RPL and Mullerian anomalies are concerned. Okay. Another thing which I want to add, which people forget, they put a probe and they never adjust the depth of the probe. Okay. You can't really put a probe and not adjust the depth. Every patient is different. Somebody's pelvis is different as compared to the other person's pelvis. please learn these basic maneuvers on a 2D ultrasound. Okay, never try to put your probe in a single direction, not rotate it. All these things are not done at all. You have to do a sagittal as well as transverse plane in the probe so that you can understand the coronal view of that uterus. You cannot miss this out. Okay, remember, one cannot really miss this out because this evaluation is going to be picked up like this, on ultrasound. To be very honest with you, just in case somebody has the facility, the best thing is after you finish an ultrasound and you suspect an anomaly. Let's say I'm suspecting a septate uterus. Put in an office hysteroscope. 100% diagnosis will come. Okay. Just put in an office hysteroscope. You will get the diagnosis. Once you have the diagnosis, then tell the patient whatever they want to do. There are many of these people, these days, over smarts, they'll be like, I have a septate uterus, but I want to think about it. What you will think? It is present since birth. Understanding that time you did not think, your parents did not think. Now what you will think, but nothing to be done. As long as you have given this diagnosis to them in writing, okay, nothing really changes. And one final thing before I conclude, people love to do MRIs. Okay. But MRIs is not very good as far as myometrial anomalies. That means as far as uterine anomalies is concerned. Okay. It is not very good. It is good for the viscera. That means it is good for bladder. It is good for rectum coming onto the uterus, posterior wall adenomyosis. It is good for all these things. But otherwise, okay, ultrasound 100% is the gold standard. Learn this thing. Okay, there are so many videos which are available. Okay, but you follow one protocol. Do not change the protocol. Follow that protocol for every patient. And trust me, you will pick up a lot of things. Okay. So I conclude with this, Arti madam. If there are questions you had, I think there was a question number 4, which probably I have not answered because I could not see that.
No problem. I'm just sharing my screen once more, Jay. Yeah. So Jay, just to summarize what you have just now beautifully outlined about how it's important to do a scan in the sagittal and transverse section and how a 3D is important. So this is just a demonstration of images where just doing a good 3D and getting the coronal section gives you the diagnosis. And just summarizing again what you said, Jay, when you're looking at the anterior compartment, we look at the bladder wall. We look at the UV fold for the presence of adhesions. You look for ureteric jets, as you mentioned, so that we know if there is associated endometriosis. And of course, kidney placement, because it gives you a hint about Mullerian abnormalities. Now, coming to the middle compartment, again, we look at the cervix. This is just like the checklist for everyone, Jay.
Yeah.
So, myometrium, beautifully, you have mentioned the importance of the myometrium and how it plays a role in recurrent pregnancy losses. And you have to look for adenomyosis and the presence of fibroids. You look at the endometrium, look for the presence of endocavitary lesions. Junctional zone is again very important because it gives us a hint whether there is associated chronic endometritis, and if there is early adenomyosis, the changes start at the junctional zone. You mentioned, of course, we should make it a protocol to look at the vaginal wall, though vaginal lesions do not really cause a recurrent pregnancy loss. And again, you mentioned beautifully the importance of a 3D scan. When you come to the lateral compartment, you look at the ovary because, again, the volume and the size and the antral follicle count of the ovary gives us an indication whether we are dealing with diminished ovarian reserve, which again is a reason for, recurrent pregnancy loss. You look at the mobility and relationship to the surroundings because if there is restricted mobility or maybe dealing with adhesions, maybe dealing with associated endometriosis, tubal adhesions, you look at the tube presence for hydrosalpinx, again gives us an indication whether there is associated pelvic infection. And pain mapping is something we should also make it a habit to include when we are doing pelvic ultrasound, because that gives us an indication whether there is associated endometriosis or PID. And then, of course, you do a scan of the posterior compartment, look for mobility and look for bowel endometriosis. And as you mentioned, look for uterosacral nodules. So this is just the entire checklist of what you should see on pelvic ultrasound when you are dealing with patients with recurrent pregnancy loss. Anything you'd like to add to this, Jay?
Madam, we must, out of all these things which we mentioned, so at the end of the ultrasound, like when we are just about to finish, we always put a uterine Doppler. Okay.
Right.
This uterine Doppler may or may not be so great as far as routine ultrasound is concerned. Okay. Or, routine RPL is concerned. But, when you have thin endometrium and when you have an abnormal Doppler, okay, this is one of the indications that the patient will not respond to stem cell therapy, PRP, all that time pass which we do. Okay, and that is something which we have started to pick up because we are doing a lot of these stem cell therapies day in day out, and we realize that if there is an abnormal Doppler, okay, with a thin endometrium, that means there is some gadbad. Okay, and we need to keep that very, very importantly in our head before doing all these things. Okay, that is one. Second, again, may or may not be like, it's not a mandate. Okay, I will say it's not a mandate, but I think it is best to evaluate the patient somewhere in the mid cycle or secretory phase of the cycle as far as RPL is concerned, because those thin bands of adhesions, those hysteroscopic synechiae which you see on ultrasound, those small bands of adhesions are really nicely picked up once the endometrium is developed a little. When the endometrium is very thin early phase, first 5-6 days of the menstrual cycle, probably it is not the best time to evaluate for RPL, is what it's the best time to operate because the endometrium is thin. But after like 10 days of the first 10 days of the cycle, that is something, it's a very good phase to evaluate the menses. A good phase to evaluate because 3D gives a beautiful contour of the endometrial cavity at that time. Okay.
Right.
I also want to state that endometrial cavity as such is not something you need to look at the volume all the time when you are doing a evaluation for RPL, because there are many patients who we think have a T-shaped uterus and they will carry a term pregnancy. There are many patients who have a beautiful endometrial volume and will have 4 abortions. Okay, so I don't think it really matters in RPL as long as there is an anomaly, but apart from this we don't really need to look into it.
Right. And I think to also add to this, Jeff, important, since we are talking about ultrasound, we should also focus on reporting. That is,
Yeah.
when you do a systematic ultrasound, please give a good report with good number of images and include your history and give a diagrammatic representation of whatever pathology you are seeing, and of course your final provisional diagnosis with suggested management also should be another take home, since we are talking so much about ultrasound here.
I agree, madam. Because see, most of the times the treatment, what we write in our ultrasound reports is uterine septum seen, recommended hysteroscopic septal resection. Simple. One can't really write kindly correlate clinically. But that's, it's okay. There is no law in the country to write down such things. But if you write it down, it is going to be good only.
Right. And just for your info, Jay, this patient who you spoke about, we just discussed about that this was the laparoscopic picture. So you can see, very rightly said by you, flimsy adhesions, and just a simple adhesiolysis was done. And this patient went ahead and even did a PCR test for chlamydia and gonorrhea, cervical swab test, and it turned out to be chlamydia positive.
Chlamydia, yeah.
And she took the entire course of medication for chlamydia, and this patient conceived, and her pregnancy did well, and she delivered as well.
But madam, you are very lucky that this patient has this picture in chlamydia. Okay.
Right.
You're very lucky, because most of the times, even if you look at the guidelines stated by Government of India, as far as treatment of PID is concerned, the guidelines are to give empirical treatment without testing.
Right.
So a lot of these patients who are chlamydia positive will receive some or the other antibiotics, which will have some or the other sensitivity to chlamydia. So partial treatment is done. And that is the worst thing. When you have treated something partially, fimbria will be open, cornua will be blocked. cornua will be open, fimbria will be blocked, something like that. And
Mm,
I am personally against that blanket treatment, but then I think probably for a large country like India, that is how it is.
right. So, this was about ultrasound in the assessment of recurrent pregnancy loss, Jay. Of course, we'll take up Mullerian abnormalities in detail in another
Yeah.
session. But since we decided we'll keep it short and sweet with lots of take homes, this is what we have for this session. Shilpa, you want to add something to what we just discussed?
I would like to ask him, what is his most commonest finding? Yes, septate uterus is one of the most commonest thing that we see in our practice. So apart from that, what are the other commonest the factors for RPL that you pick up routinely in your practice?
See, madam, the most common is a normal finding as far as RPL is concerned.
Correct.
Okay, everything is normal. Okay, then patient will be very angry at you that you charged bloody 5,000 rupees and you are reporting everything normal. But that is the commonest thing. I think the second most commonest in our country, and something which is missed out by majority people, is endometritis. Okay, it is really missed out. Okay, and you will be surprised the minute you see endometritis or you suspect endometritis. Arti madam said no, there is going to be a little haziness at the endomyometrial junction.
Mm.
I think what is important to understand is that apart from this haziness, no, they will have that little motion tenderness also. That cervix, when your transducer probe touches the cervix and you try to move it up and down, no,
Yeah.
okay, there will be little bit of that motion tenderness associated with that PID. And
Right.
again, in this, one of the best things to do, I don't think it is specific at all, and I think we have started doing it since 1-2 years, and I've shared it with you also, Shilpa madam, but I don't think it is so great, but we do it. Okay, we add a Doppler and look at the parametrium. Along with this, the congestion in the parametrium is there. Then you do an office hysteroscope, you will find some endometritis. Just give antibiotics for 21 days. And I think I have lost count.
Yeah.
Vismaya has 100% lost count of how many people become pregnant after that. After 3 cycles, they are pregnant. And suddenly they are like, oh, what a great doctor. He did office hysteroscopy for 25,000, did not do anything, just gave some antibiotics, and in 2 months, I'm pregnant. Okay, but that is that endometritis which we pick up, like how we had picked up for somebody in Bangalore, on doing that hysteroscopy, and that is the most common finding, madam. See, the septums, what we are talking about, the bicornuate uterus, what we are talking about. By the time the patient reaches us, they already know it is bicornuate uterus. By the time they reach us, they already know it is a complete septum. You know, they have just come for inquiry to understand how much we are going to charge about it. Otherwise, somebody would have told them that, you have a complete septum, we'll do a 5 sitting surgery. First, we'll cut 1 centimeter, wait for 2 months, cut another 1 centimeter, like that. Then they will come and ask us, sir, will you do it in single setting? And Vismay will be like, no, we do it in office hysteroscopy. So then they'll get scared and run away. That, are he's doing it without anesthesia, something like that. But then that is the most common thing which we see at our level. Okay. Of
No,
course.
I think that is very different what you said. But see, I think we should divide RPL as in patients who come with fertility issues also, and patients who are conceiving naturally, but they end up in aborting. Okay,
Yeah.
so these two are different categories, is what I feel. And ultrasound, as you rightly said, it has to be done in mid-cycle or secretory, but at the same time, we should do 2 sittings of ultrasound. See, what I usually do is I track for the natural cycle. I tell them we'll just do a natural cycle monitoring where I do a scan on day 2, day 3, scan on day 10 to day 12, one of those times when she is, if she is ovulating, and then just a premenstrual scan probably on day 21, day 22. So in these 3 sittings, I mean, I just see as to baseline whether it is a PCO, whether it is diminished ovarian disorder, which is very common in infertility associated with RPL. If it is normal, so that is again 50% of the RPLs are idiopathic, which we don't know. So those are the cases which is very frustrating, is what I feel. And of course, in Mullerian, yes, I mean, people write all sorts of reports saying that it is bicornuate, it is diadelphys, it is bicornuate, bicolis, bicornuate unicolis, all those sorts of the things. And but most of the times it will be a septate uterus. So if you have a doubt, just put in a laparoscope, check, and then do the resection. Not like, like you who does it in office hysteroscope, but for people who are not doing so much of work on Mullerian anomalies, I think it's extremely important to get get the right kind of idea before they go on doing MRIs on MRIs, go on doing 3D scans on 3D scan, just to do whether the septal resection to be done or whether to leave it alone, whether it is a diadelphys. So patient would have done multiple scans, multiple MRIs, isn't it? So
yeah, that is the best way to confuse a patient, 1.5 centimeter septum, and you are debating, oh, should I cut? I should not cut. Wait, let me attend
can't do
your
that.
workshop,
You can't do all
So
that.
such type of things don't really work. In my opinion, if there is a septum, if you have seen a septum, okay, what are you thinking about? Just go and cut. Okay. What is the harm in cutting something which is abnormal? Right? I mean, I don't, it's like somebody debating. I have a 1 centimeter polyp for a fresh transfer and I'm scratching my head. Shall I remove the polyp or shall I give some criteria or guideline where you put the embryo? I mean, I don't know. In today's time and age, such things should not be done, in my opinion.
Yeah, I think that's about it.
Yeah, Shilpa, actually, I like that take-home point you gave about doing an ultrasound at different phases of the cycle, a baseline, mid-cycle, and a premenstrual, because I think each phase of the menstrual cycle gives us different information.
Idea. See, the patients are extremely happy when I tell them, I'm not going to give you any medicines apart from folic acid, but I would just like to see you.
Right.
Just for me to get an idea before I do any kind of, say, the next invasive testing like a hysteroscopy or do a ovulation induction. I just want to monitor a natural cycle. And the acceptance is extremely good. You get so many points where you know whether the patient is ovulating, not ovulating, whether there is a synchrony between the endometrium, triple line is there, not there, whether post post ovulation, whether there is any other factors which is contributing. So many things, I mean, I think
Yeah.
we can get to know.
Yes, we do the same thing, Shilpa, the same protocol, and I totally agree with you. And just to add to what was said by Jay about how we miss chronic endometritis as one of the causes for RPL, like I just discussed in the case, these are like subtle minor markers, probe tenderness, and even these echogenic bright spots on the ovarian stroma. When you see, that is also a very subtle sign that maybe we are dealing with a PID, subtle form of PID. Also, when you see hazy ovarian borders, when the ovary is displaced above the uterus, and when you're doing the sliding sign and it is not sliding down to its normal position and it appears to be adherent, when there is restricted mobility of that ovary, and of course, when the junctional zone is very hazy and ill-defined, with again bright spots at the area of the junctional zone, I think these are also important minor markers for a chronic PID.
Yeah.
Which has to be further investigated.
True. Very true.
Yeah. So I think with this we'll end today's session. It was wonderful, good take homes, very practical, and the questions maybe we'll take in the group later.